Thank you all for being here. Today I'm going to talk to you about why the reverse replacement is gaining popularity. And the primary question is the growth of the reverse due to its advanced effective design, or is it possibly being overutilized in some cases by orthopedic surgeons? To understand the reverse, we need to have a little brief overview of shoulder anatomy. Shoulder is a ball and socket joint composed of the glenoid being the socket and the humeral head being the ball. The relative size of the glenoid to the humeral head likens it to a golf ball and a golf tee, with a great range of motion but with an inherent instability. To overcome this, there are static and dynamic stabilizers. Static stabilizers include the glenoid, the labrum, the capsule, the glenohumeral ligaments that keep the shoulder joint aligned. The dynamic stabilizers involve the rotator cuff and the long head of the biceps, which provide the shoulder's dynamic movement and keep the center of the head in the center of the socket. Glenohumeral arthropathy or disease of the shoulder has risen with the aging population. It is now the third most common large joint affected. There are several different types of shoulder arthropathies. Primary osteoarthritis occurs with an intact rotator cuff and is primarily degenerative in nature, what we think of it as osteoarthritis. Secondary arthropathy develops after trauma, joint infections, inflammatory, and other conditions such as rotator cuff arthropathy, which is defined by massive rotator cuff tear, resulting in loss of the force couples, or the humeral head being in the center of the socket, humeral head escape, cartilage destruction, and subchondral osteoporosis. This condition significantly affects the shoulder's stability and function. Now, surgical management of osteoarthritis produces excellent and reliable functional improvements for primary osteoarthritis. But traditional surgical treatments for rotator cuff arthropathy are limited and produce suboptimal outcomes, particularly when addressing both the degeneration of the joint and the rotator cuff deficiencies. This treatment gap sets the stage for the development of the reverse total shoulder arthroplasty, designed to manage those complex cases with better stability and function. So what is the reverse? The concept of the reverse was first introduced in the 1970s. It's motivated by, again, the need for the better outcomes with patients with anatomic shoulder replacements were ineffective. Traditional anatomic shoulder arthroplasty is where the prosthesis mimics the natural shoulder joint, where there's a concave glenoid socket and a ball-shaped humeral head. The reverse is reversed. The glenoid ball, the glenosphere, is paired with a concave humeral component. This inversion allows the shoulder to function even with a deficient rotator cuff. The ball and socket prosthesis is a semi-constrained design based on 4 fundamental principles. What's called the medialization of the center of rotation, which reduces the torque on the glenoid component, minimizing the risk of loosening. Lowered humerus, by lowering the humerus, as you can see on the right side. The deltoid muscle is effectively lengthened and enables to compensate for rotator cuff deficiencies. A fixed fulcrum design, this improves the moment arm of the deltoid, enhancing its function as an abductor. And then a large glenosphere, a larger ball component, increases the range of motion for the shoulder. These designs have led to the popularity of the reverse, making it a preferred choice for complex shoulder conditions where traditional approaches have failed. So the reverse total shoulder was utilized in Europe in the 90s and early 2000s. It wasn't FDA approved until late 2003, early 2004, but it was only approved for 2 different indications. Grossly rotator cuff deficient joint with severe arthropathy, that rotator cuff arthropathy patient, and previously failed joint replacements. Those are the only 2 FDA approvals. But early outcomes were marred with pretty significant complications, up to 60%. They include what's called scapular notching, where the humeral head hits the glenoid bone, hematoma or blood infection, periprosthetic fracture, component loosening, dislocation and instability, and neurologic injury, forcing some surgeons to come out and say only use the reverse with treatments that can't yield acceptable outcomes. Secondary to this poor outcomes, there was a boom in research around reverse. In 2010, there were only about 44 different citations in the PubMed. Now there's over 500 in 2013. And these studies and their outcomes have started the rise of the reverse over the last decade or 2 decades. In 2003, again, it was FDA approved. 2011, there was approximately 23,000 surgeries, and last year there was over 100,000 reverses. You can see on the top right there, the reverse is in blue. It is going up significantly. So is the anatomic total shoulder, again, because patients are getting older and older. But what we see here is also the hemiarthroplasty, which is also going significantly down. So the reverse has taken over what the hemiarthroplasty has done. There are multiple different factors that account for the rise in the utilization of the reverse. They include experience. It's now been 2 decades since the FDA approved it. Implant design has significantly improved over the course of the last 2 decades, improved surgical techniques, computer navigation, patient-specific implants, augmented reality, improved research and recognition of different infectious organisms. So traditional reverse were first defined in 1985 by Paul Grammont. They addressed the problems that we see in traditional design and complications seen previously. Recent innovations include what's called glenoid lateralization, decreases the risk of scapular notching, but it may increase the risk of loosening. So evidence of loosening rates are mixed, suggesting lateralization has both benefits and trade-offs. Humeral component adjustments, lowering the neck shaft angle from 155 to 135, enhances external rotation and reduces scapular notching without raising dislocation. However, increased deltoid tension may raise the risk of scapular fracture, which warrants further studying. Stemless implant designs offer bone preservation and reduce stress, shielding, but require strong or proximal bone, and show mixed results regarding scapular notching, and long-term outcomes are still being evaluated. Overall, while promising, these designs changes need further investigation. Proper glenoid positioning is also crucial for the success of the reverse, as malpositioning can lead to complications and humeral instability. However, achieving glenoid placement is difficult and technically challenging due to complex factors like anatomy or poor visualization. So recent innovations such as computer navigation and patient-specific instrumentation aim to improve that accuracy in glenoid component positioning. Mixed reality is where you use augmented reality to help you guide the implant into a better position. So since its approval in 2003, the reverse total shoulder has undergone significant changes in the surgical indications and patient selection. Initially, reverse was intended for a specific group, low-demand elderly patients suffering from painful pseudoparalysis due to rotator cuff arthropathy. Given these narrow indications, early projections suggested that reverse would be a small fraction of shoulder arthroplasty procedures, mostly relying on the hemi or the traditional total shoulder arthroplasty. However, over time, that scope of the reverse has broadened significantly. Expanded indications now include younger patients, 60 to 65 or below. Despite early concerns about implant loosening and high complications rate, recent studies show that outcomes with implant survivorship of around 91% at 11 years. Meta-analysis confirmed that rotator reverse shoulder offers reliable function and acceptable revision rates, supporting its viability in younger individuals. Primary glenohumeral osteoarthritis is increasingly used, reverse is increasingly used for osteoarthritis with an intact rotator cuff and significant what we call posterior glenoid wear or malformation of the socket, where traditional anatomic total shoulders did not get a particularly great outcome. Studies showed that reverse semi-constrained design produces better outcomes, particularly in cases of severe glenoid bone loss. So consequently, reverse is now considered a viable option for patients with complex glenoid deformities. Chronic instability and massive rotator cuff tears, even without any arthritis, is another expanding indication. Acute fractures and trauma-related complications. Reverse is increasingly used to treat complex 3- and 4-part proximal humerus fractures in elderly patients, particularly in cases where a hemiarthroplasty outcomes are poor due to issues like tuberosity malunion, non-union, and post-traumatic arthritis. Studies show that reverse provides better clinical outcomes, including higher clinical scores, greater forward flexion, and improved tuberosity healing compared to hemiarthroplasty. While some studies report increased complications with reverse, others note similar or even reduced complication rate. And then reverse is still a viable option for a salvage procedure for complex shoulder issues. And then here's kind of the percent of all reverse for indications over time. As we see in 2017, there was an inflection point where the reverse for osteoarthritis with an intact rotator cuff overtook the indication for reverse without an intact rotator cuff. So in summary, the use of reverse total shoulder has continued to rise to almost 70% of all arthroplasty cases. Its unique ability to address complex shoulder pathology in young and old make it a very versatile tool. However, we must remain diligent with continued research to help refine the indications and to address any complications.